Hello, everybody, and welcome to this summer shorts episode. I feel like I'm a TV presenter, it's great. I'm here on behalf of the King's Clinical Academic Training Office and the King's Centre for Research Staff Development. My name is Simran O'Brien, and I'm a consultant here at King's College. We've got a great programme for you today. We're joined by Gemma Jones, who is KHP WCH Programme Director, and Manon Devreese, who is KHP WCH Research Support Manager, and they're going to be talking about costings for funding applications. I just want to say a big shout out to the KCATO team who've been working with us all to put this together. It's really exciting. So we're here to answer any and all questions you may have. So feel free to post them in the chat as we go, and we'll come back to them at the end. And likewise, we are going to be recording this session. So if anyone needs to dash off at any point, you can catch up with them on the recording, which will be shared after today. So a little bit about KCATO. Well, KCATO has a mission to facilitate and support world-class pan-professional clinical academic training across King's College and our NHS Trust partners. So that's really focusing on enabling all health professionals, regardless of which type you are, to become clinical academic leaders for the future. And they sit within the King's Doctoral College, which is part of the Research Talent Directorate within King's College, working quite closely with my team in the Centre for Research Staff Development. We provide bespoke training specifically for research staff like yourselves. So we also offer one-to-one workshops as well as coaching appointments or mentoring to really help you think about your career and to take time out to make it work for you. We have bi-monthly mailers, which will really highlight the most important topical conversations happening both within the sector and within King's, signposting to opportunities. And we likewise provide the same types of support to your managers in terms of training. We have got bespoke workshops for them as managers of research staff, as well as guidance and resources relating to their roles so that they can effectively support you. As part of the CRSD, we also have a research staff network that we support, as well as the Research Staff Representative Committee. And my role is kind of act as the intermediary between all these groups. So I take out the best practice and the learnings and the challenges that are being shaped by research staff, and I share that upwards with senior management and vice versa. I report down so that we're all working as effectively as we can. And we monitor everything we do at the CRSD to really understand that the research staff experience what's working, what could be better. And all of this is in aid of fulfilling the Researcher Development Concordat, which King's is a signatory to, and we use that to really monitor the way in which we're effectively supporting you. A quick signpost to some of our training that we offer at the CRSD. So we've got a wealth of resources here. And as a member of King's College, you would be entitled to 10 development days per year pro rata to dedicate to your professional development. So you can use that in a variety of ways, whether that's to do with attending workshops like some of them listed here. We've got writing and publishing, leadership, career development, and newer additions like AI. So if you're thinking about wanting to focus on a development goal, we can help you to create that and define that and create a plan around it so you maximize your engagement with your development days. But there's so much more that you need to be able to do. So we're here to help you through that. And as I mentioned, we are fairly active in terms of social media. You can connect with us through our internal pages by searching for the CRSD on the intranet. Likewise, via mailers or even our event series, we have things like the Research Staff Forum, and we're going to have something in the autumn called the 10 Days Festival. So please do keep an eye out and engage with us. You can also give us a follow on LinkedIn or X to find out more, and scan that QR code just there to access our pages. All right, that's enough about that from me. We're going to move into the session now, and this is just really a great opportunity to remind you all that this is a safe space. So be curious, really think about what you want to get out of today, be compassionate, really respect other people's views as well as your own, and stay present in the moment. I think it's very easy for us to just get sidetracked and check email. So let's try and all be present today for the next half hour. And likewise, always be yourself. Feel free to ask questions at any point by posting it in the chat. Right, I'm going to hand over to Gemma and Manon to kick off the session. Thank you.
Hi, everyone. Just to briefly introduce myself before we get started, my name is Manon Devreese. I'm a King's Health Partner Women and Children's Health Research Support Manager, and among my different responsibilities, I offer pre-award grant application support to research active clinicians across women and children's health wanting to apply for funding. So this session is going to focus on research grant costings. Yep. Sorry, trying to take control of the slide deck. Yep. And before we get started on the details of costing, I wanted to highlight a simple but very important point, which is that research isn't free. In fact, it costs quite a lot of money. And regardless of a project, of how it is innovative or compelling, then every principal investigator will have to seek funding for a project to be able to run. Here you can see on this diagram a very simplified representation of the pre-award process, which starts with a research idea, then identifying relevant funding stream, writing a proposal. You have further steps within this item, submitting the proposal, having it reviewed, and then if successful, a contract is set up and the research project can start. And in the next few slides, we will focus on just this small item, which is budget and resources. And while the process may look simple and linear, in practice, the steps can be more complex than it seems. And the step within the writing your proposal are actually interdependent, because the hypothesis is going to impact methodology, which in turn will very much affect the budget, and the budget overall is going to affect the project scope. So this is, while I know it is often seen as perceived as secondary, the budget is actually crucial. It is essential to a proposal's success. Yep. Sorry. Yep. And it is essential because it is going to increase the likelihood of funding in different ways. First, it ensures that the proposed budget will align with the project requirements. It reflects that the researcher understands the scope and the complexity of the project. And so it increases the researcher's credibility. It helps funding bodies assess the feasibility and sustainability of the project. And then later on in post-award, if awarded, then it facilitated significantly the effectiveness of project management and resources allocation. But most importantly, the accuracy of research costing is going to foster trust. And trust is essential not only for the funder, who needs to be confident that in the project's deliverability, but also to the host institution, which will be the one bearing all the financial risk. In addition, there's also a reputational risk for the host institution, and miscosted budgets can very much damage an institution credibility, and in even some cases, it can lead to funders withholding and withdrawing all future funding. Yep. So now that we've seen why it is important to accurately cost research, let's dive into the terminology. So first we'll look at terminology in proposal when it's led by an academic institution, and then we'll follow to NHS and clinical trial specific costs. So here on this slide, you can see a table with an example of a budget from a grant application that is led by a university. You'll see that there's different categories: cost to the higher education institution, cost to funder, price to funder, and then you have different types of costs. But what do they mean? So there's a real difference between costing and pricing research. and often those terms can be misunderstood and misused. So costing refers to the total cost the university needs to use to carry out the research, and it is calculated internally using the full economic costing model. It is a standardized way of calculating the true cost of undertaking research, and it will vary from one institution to another because every institution, even for the same research project, will have different running costs. And then we have pricing, and the price is basically the amount that is going to be requested from the funder. It is shaped by the funder's terms and conditions, and contribution will vary depending on the funder. Just taking in mind the table here. Sorry, trying to get to the next slide. Yep. So going over the different cost types. So we have directly incurred, directly allocated, and indirect costs. So directly incurred costs are going to be all the costs that are directly attributable to the project, and they are explicitly identified and recorded against the project. So that's costs such as staff, consumable services, etc. Directly allocated costs are costs that are attributable to the budget, to the project, but they are shared resources, which means that they are estimated rather than directly recorded. And that's, for example, staff that are already on payroll, estates and infrastructures costs. And then lastly, we have indirect costs. So it's all the costs that are not directly attributable to the project, such as wider professional services support. And so going to the categories, cost to the higher education institution is always 100% of FEC, and that means that it includes the directly incurred costs, the directly allocated costs, and the indirect costs. While cost to funder is the estimated total value being applied for, and price to funder is the estimated total value to be awarded. And if you remember, I mentioned that funders are going to contribute differently. And for example, usually UK Research Council will only pay 80% of the full economic cost of the research. UK charities 100% of only direct costs, and commercial will be expected to pay 100% of FEC. And when the funder is not paying 100% of FEC, then it's for the university to cover the shortfall themselves. And just to mention that if you are applying to different scheme from the same funder, sometimes you will have different terms and conditions and different contribution, and it's always good to look at the policies. So now looking at NHS and clinical trial specific costs. So when research takes place in an NHS setting or involve NHS patients, the patient staff or facility, the cost must be attributed according to the ACORD framework, which is a national set of guidelines used across England to separate the cost appropriately between the NHS funder and NIHR research delivery network. So there's 4 main categories of costs. Here we have the research costs, which are non-care costs that are directly attributed to the research project. For example, that's going to be staff, consumable equipment, etc. There's the NHS treatment costs. So those are the costs of the standard of care provided to the patient regardless of their participation. And it's going to include anything like routine medical treatments, procedures. Then there's NHS excess treatment costs, which are additional costs that arise when the study involves intervention that go beyond or differ from the standard of care. And then finally, we have the NHS support costs, which are additional patient care costs that are incurred to support the delivery of the research within the NHS setting, and that can include a lot of different things. So just to mention that usually the funder is going to be expected to cover all of the research costs or part of the research costs, the NHS treatment costs, and then the local research delivery network is going to cover the NHS excess treatment cost and support costs. And to obtain those costs, applicants will need to complete an online form called the KCATO, and they can request support from their local accord specialist, who will have to also approve any cost before they can be inputted into a grant application. So handing over to Gemma now.
Thanks, Manon. Can you hear me? Is that good? Yes. Sorry, I have a mic problem, so I'm hoping it's going to hold out. My name is, as said, Gemma Jones. So I head up the King's Health Partners Women and Children's Clinical Academic Partnership, and I have a career history in running large-scale research studies and applying for lots of these types of grants. So I'm just going to take you through in a little bit more detail the research costs. It is rather like a shopping list. It seems quite straightforward when you're just looking at it on a list, but actually there's quite a lot of complexity behind some of those things. So these are broadly divided into staff and non-staff costs. So staff, i.e. people, and non-staff, i.e. things. So I'll kind of go through those. And just a reminder, as Manon said, your directly incurred staff, your DI staff, are the cost of staff that will stop once that particular research project stops. So if you're recruited to run a particular project, you know that you may be on a kind of a temporary contract and have fixed term funding compared to your directly allocated staff, so those people who are directly employed by the university. So that will be kind of your principal investigator, etc. So if you're those professors, but the expectation from those people employed by the university is that they do have to recover against those costs as well. So the university does expect them to, as you know, win research grants and then therefore recoup costs via these DA costs. For example, KCATO asks for a 10 to 15% minimum for anyone on a co-applicant on any research study, and a principal investigator may well be more than that. And it really does need to reflect the time that an individual will spend on the study, because you can't, some of these larger research studies do take quite a lot of investment from all members of staff, including the senior members of staff. Also, as a reminder, there's normally a lead applicant for your research costs. So, and that's normally the substantive employer of your principal investigator, the person applying for the money. And then that's also divided out into partner costs. So, if you're working with the NHS and certain costs will be incurred within the NHS, you have to speak to them. And then, or even other universities and collaborators. As we know, research is quite a collaborative process. So you're likely to need costs and quotes from quite a broad range of organisations when you're pulling something together. Just should you get the money comes to the lead applicant and the lead organisation, and then is distributed via contractual agreements out to those other organisations. For all staff costs, you're going to need the duration and grade, and then your organisation will cost those with the right overheads to account for things like national insurance, pensions and their overheads, etc. So therefore, it's really this circular process that Manon mentioned at the beginning. It's really important that you know the full duration of your project based on the logistics of how you're going to recruit participants, how the different stages are going to come together, because you need to be able to say to the person in finance or to put onto your own work tribe system to say how long that person's going to need to work on that particular study, including dates. So forecasting that you might be starting this time next year and you need someone for 4 years hence. And not all staff may be required for the full duration. So if you had a research nurse working on your study, they might not need to set it up, but they'll be needed within the hospitals later. Although some staff, it's easier to cost an average over time. For example, if you've got to work with a statistician, they're likely to have a peak of work at the beginning and at the end as they do analysis, but they will be required throughout the duration of the study. So you might want to to kind of put a flat cost across that. I think that covers the staff costs. So I'll move on to non-staff costs. Consumables are things that will be kind of thrown away, as kind of does what it says on the tin, and you need to think about all the different things and all the different things that other people will need in your study. We come down to equipment. It's important. Some things will have a degree of permanency, so it's not a pipette tip that you'll throw away, but some of that permanency will only last for the duration of the project. For example, a laptop. Actually, we now consider laptops largely kind of out of date once they may be 5 years old. If your study lasts for 5 years, then you'll may be able to buy a laptop on the study, but at the end, actually that then becomes defunct. First, there might be the case of having some larger equipment costs, something enormous like an MRI scanner, which then might be available after the project, although there are often large restrictions on those types of costs as they're expensive. So it's really important to, even things like laptop costs, as I've just mentioned, will be maybe capped within the researcher's terms and conditions. So important to look into exactly what the instructions say. It's also useful to speak to whoever will host the equipment. So around maintenance, storage, for example, you need to think about if something's going to patients, you need to think about things like infection control, things like calibration. If you are, for example, distributing devices out to patients during the course of your study, either for kind of, step counters, things like that, then the number you will have will impact the rate that you can actually recruit to that study. So unless you have an infinite number, you need to cap your recruitment, which in turn might affect the duration of your study. So you can see how all these things interlink as you go through the process of planning what you're going to do. For example, I worked on a study where we were using VR headsets for an audiology intervention. And so we really had to think about how we'd get those VR headsets out to the different sites. It was all the way across the UK, out to the children who are going to be using them to use the intervention, and then back again so that someone else, they could be, kind of reprogrammed so that they could go out to another child later. So that's equipment. Then we're moving down to things like research facilities. It's really important to speak to your research facilities ahead of time. You will require quotes from them. As I said before, all partner costs are likely to require quotes, but do get quotes from any internal departments as well. Just because something's within either your university or your trust doesn't mean you should just kind of make up the cost. You really need to speak to them and get them to cost that for you up front. For certain quotes and certain values of money, there'll be requirements around procurement and possibly tendering for very large costs. So, for example, in KCL, if you're spending over £10,000, you have to get to at least 3 different quotes to make sure you're getting value for money. But please do speak to procurement within your respective organisations to confirm things like that, because it's really important. And then VAT may or may not be applicable. Largely, VAT is not applicable during research studies and in hospital settings. However, there are exceptions. So if you're not used to that, again, you can speak to research costing people or the VAT office, perhaps. You might be able to seek advice. So within research facilities, we specifically mentioned databases and randomization. It's really important to consider where you'll record your study data, maintain it, and ensure those data can be recovered and reconstructed. So something like Excel is not usually preferred. It doesn't have the right requirements, so it's better in a robust system. Your data are better in a robust system. Some are free, some are provided by the university, but sometimes if you're using more complex methodologies in terms of something like randomization and you want stratification, then you might have to seek a service that is paid for and specifically built for your study. So again, kind of don't rely on the fact that you could put something, maybe a smaller study, you've used the KCL Qualtrics, but you're then going to do a larger study, you might need a more specific system built for your particular research study. So please bear that in mind. Moving down the list, we've mentioned research studentship fees. I think that's fairly obvious. Costs for audit, monitoring, checking information. So that may be an internal or an external cost. Insurance is usually provided by your institution at a kind of institutional level, but there are always exceptions to the rule. For example, sometimes if you're working overseas or working with pregnant women, there will be exceptions, so it's important to understand who will insure your study. Patient participation, involvement and engagement. I've actually kind of got a little bit more detail about that on the next slide, so we'll go to that later. I think IT services, license fees, application fees all kind of come under the same umbrella and are fairly self-explanatory. But for example, some questionnaires have license fees and you have to pay the producer. You can only use them in the format that they've been designed in, and sometimes you have to buy that directly from the person who has both produced and validated that particular questionnaire. So again, don't make an assumption, check. It's always better to have checked sooner rather than later. And finally, dissemination costs. Don't forget these. So they can come when they come at the end of the study, people often panic and they don't have the funding available. So that might be publication costs for journals, but also maybe public and patient dissemination, events, printouts, things like that. So important to keep that budget for the end of the study. We mentioned specifically patient involvement. So patient involvement is often missed, and I think people are getting better at it, but it's really important to cost up front. And before budgeting, you need to know how you will be involving members of the public. So it's worth having conversations with PPI experts to think about the types of expertise you might need. Is it someone who's a co-applicant? Is it some focus groups? Do you need translation? All of those types of costs. And there's a really useful calculator and guidance on the NHR website. I'll put it in the chat. It's called the Involve Toolkit. But to use the toolkit, it does tell you do need to know what you're going to do before you use the toolkit. So it's important to know that. Moving on. So I hope you can see this slide. It might be a little bit small. And this is just a little bit around the process that we need to go through when doing a research budget and the timeline. So stage one says, so this is working backwards from your funder's deadline. Allow at least 6 weeks to have a finalised version of your methodology and your plans for the study. I would say actually bearing in mind all of the things I've just said, the longer the better. So, you might be working on this for up to 3 to 6 months before putting an application in, depending on the complexity of the study. So as mentioned, the next stage, once you know exactly what's going to happen in the study, you're happy that you know all of the timelines, then you need to request the salary costs from both your collaborators and your host organisation, NHS costs from an NHS organisation, and all of the quotes that we've mentioned for other equipment, services, etc. The next part, number 3, there might be brief risk assessments that you need to do on the system. WorkTribe certainly has a risk assessment. You might need various R&D lead approvals and all kind of top-line ethics approvals as well in place before moving on to finalising your budget. So once you've got signed off costs for everything, that's when you can start to work on the funders portal. So each of the funders you're applying to will have their own system where the information needs to be entered. Each funders portal is slightly different. They require often a lot of detail. They're quite often quite difficult to navigate, and they do require quite specific breakdowns depending on the funder of per year, maybe breaking down between the overhead costs. So it's important that some people, there are people, Manon can do that for you if you're working with women and children's health, and then you can seek advice obviously from your costing experts. Once you've done that, then your budget doesn't go directly to the funder. It actually goes to internal finance approval in all of the organisations and that you will be working in, so both across the universities and trusts. So you can submit that to finance for approval. They ask for 10 days to do that. They will then return that to you, having signed it off, hopefully, perhaps with some questions in between. And then you are able, or your principal investigator is able to submit that onto the funders portal. The funder may then send institutional approval back to your organisation. So it's kind of, you have to work really within the system you have to be very sure and finalize things up front, because any changes often do things like knock all of the signatures out. So if someone in your organization has completed their institutional signature and a change is made afterwards, it will invalidate the whole form and you'll have to go back and get that approval again. So it's just really important to kind of allow yourself enough time, because no matter how well planned these things are, often you don't anticipate those changes. So I think that we'll move on to the next one. So just finally, some top tips. As we've said over and over, before requesting your costs, create a detailed project timeline, use a Gantt chart, use some kind of planning, and estimate your resources. Collaborator meetings, discuss your local requirements, work with your collaborators and make sure everyone's on the same page and is going to affect this in the same way. Use your PPIE guidance to shape your study and also to the costs you're going to need during the study. A lot of this information, a lot of people make the mistake. Most funding applications are divided into 2 stages. Sorry, we will be finished in a minute. Stage 1 and stage 2. You are normally allowed a little bit of wiggle room between stage 1 and stage 2, but really you have to do a lot of this, even though they only ask for headline figures in stage 1. If you don't get that right at stage 1, you have very little flexibility by stage 2. So you can normally only vary by 10%. If you've missed something large, then you've not got that flexibility in order to be able to do that. And the final point is use the training, especially for things like the complex things like the KCATO and the funders portals. There are guidances online, and that's why it's worth doing something way in advance so that you can use those training and not panic at the point that you're trying to make the submission before the deadline. So thank you very much. Inform yourself about institutional processes, allow sufficient time. I don't think we can say that enough, and identify your key contacts and the support available. So I think we were going to take any questions in the chat. We are happy to stay online for another few minutes. Sorry, there are obviously some questions in the chat. We'll stay online for another few minutes. So those of you that can stay and would like to, please do. If not, thank you for your time. This has been recorded. I hope that will come out to you via KCATO shortly, and then you can also forward that on to any other interested colleagues. So thank you very much for your time.
Thank you, Gemma, and thank you, Manon, for a really great presentation. As we have a question in the chat, let's get started with that, shall we? So we've got a question here around what would be your suggestion on revising a budget if a project is receiving positive feedback from the reviewers, but was asked to be revised as the funder can only match a smaller amount of money. They've suggested that, well, if you had to reduce from, say, 200k to 50k, that's quite a dramatic decrease there. So any thoughts or suggestions?
Yeah, as you've just said, that's quite a large reduction. I think under some circumstances, you're applying for the wrong scheme. So, actually, if you want to keep your study looking like you've proposed, can you cut anything in terms of size, do a pilot study? Quite a lot of funders will fund perhaps 2-stage studies. So you have a pilot once you've proven proof of concept and proof of recruitment and things like that in the pilot stage, then they'll be able to release further funds and you have an application for the larger study. The other thing is to look for co-funding, maybe. So look for another funder or another kind of a commercial organisation who might be able to kind of top up. That is a large, and you can always make a bit of wiggle room, but I wouldn't say you can cut generally a project by more than kind of 10 to 20% on request of the funder. Worth looking at in detail at all your costs, I suppose, is my answer. I don't know whether, Manon, you want to add anything?
Not really. It's really good point, but I would say this is such a dramatic reduction that you cannot deliver the same project with 50k than 200k. So you will have to look at the overall scope of the project, knowing that it is not deliverable as it was suggested in stage 1. That's just a fact.
Thank you. Some really useful advice there, and hopefully you can take that forward and find a way to take that. Yeah, I can see there's some really helpful feedback there. I also had a follow-up question. I guess it's somewhat in association, but when it comes to making these grant applications, is it better to overestimate when it comes to budgeting than underestimate? Could you have like a reserve pot of money that you include, or is that strongly discouraged, shall we say?
So yeah, no, it's not encouraged. You should not overestimate your budgets, because funders, as I mentioned, there's this relation of trust that's very important. You cannot just overestimate your budget, then it's lying basically. It's very important that you stay true to fact, and the university is not going to let you overestimate your budget anyway.
Yeah, so it's having that real clear idea about what you want your project to include and funding it or costing it on that basis.
Which can be quite frustrating in that if you were in industry, you'd always have a contingency pot. So, kind of think about that. But actually, most funders, if you have a reasonable change to your budget and your study, you can approach them and at least have a conversation. And that might be sometimes moving money from one part of your budget to another. So where you might have underestimated in one part, you may have underestimated in another. So they're quite flexible to that movement of costs. And sometimes there may be additional funding available that you can apply for. To then kind of, if there was something significant that had been missed and appeared to be not to be unanticipated and beyond your control. For example, if a drug supplier puts their costs up or something becomes unavailable in your country or something like that, you can often have that conversation.
That's great, thank you. If there are any other questions, feel free to pop them in the chat. Alternatively, if you can, raise your hand. We're more than happy to facilitate that way. Otherwise, I think we might draw this session to a close if there are no more questions. Oh, here we go. Here's another one. So one from Colette. I'm a little confused regarding this. I'm not even going to pronounce that. So ECAT form. Previously where I worked, the CRN completed this for a project I was working on. Here it looks like we are responsible for it. So maybe Manon and Gemma can clarify.
So yes, if you are working with partners who are NHS Trust, then yes, you will, as a principal investigator, you will have to complete the form. But again, as I said, there is local accord specialist, and they're always, if you contact them in advance of the submission and you allow sufficient time, they will give you guidance. There's also lots of training on the SOICAT, but yes, there is no one at the university, apart maybe someone that's knowledgeable within your own department, pre-order support that may be able to help, but usually it falls under the principal investigator responsibility. But again, lots of training, and the local accord specialists for the trust are always happy to help completing the form. Gemma, you want to add anything?
Yes. So when SOCAT first came in, the CRNs were completing them. I have found in time they have then moved that responsibility over. So I don't know how long ago it was that was completed for you. They will help you and they will review. The CRN's now called the RRD end, just for reference, the Research Delivery Networks. So yes, I hope that answers that.
All right, and for those of us less familiar with SOCAT, what does that stand for?
There's an attribution of cost attribution. We'll look it up. Cost attribution template is the end, I think.
All right, thank you. One final question before we wrap up. So how about participant attrition? How can we cost to account for that?
Do you want me to take that one?
Yeah.
So I think I'd take a multi-pronged approach. One, costing for and making sure your study is acceptable so you get less participant attrition. Trying to minimize it as much as possible by engaging with your PPIE to make sure that the study is acceptable. Secondly, your sample size calculation probably should account for that. You should be able to account for a certain amount of dropout. And if you, most funders, if you put something, depending on the, so if you've got evidence for previous dropout and previous studies, you know, not even just your evidence, but external evidence that a particularly difficult group to retain, then you will be able to kind of have more of that. But as a ballpark, I'd kind of put 10 to 20%. And thirdly, your power calculation should also then, you know, kind of have how much you need to get to kind of 80 or 90% power. So you've got a little bit of kind of attrition in there. I'm not a statistician, so I've probably articulated that poorly. But yeah, definitely minimize it as much as you can. Use the evidence you have available from previous studies, and try and keep as many people in as possible via whatever kind of is appropriate for your particular patient group.
All right, thank you very much to you both for answering those questions. And if anyone else has any more questions, I'm sure we could take them. But in the meantime, I'm just going to move us on to signpost you to the rest of the Summer Short series with KCATO. So on the 15th of July, we've got one on cultural competency in health research. And then on the 22nd of July, there's one on translational research. So what is it, and does my research fit? Please do engage with those. I hope that you find them really useful. And if you'd like to connect with KCATO, you can contact them on the email address at cato@kcl.ac.uk. They also have a website as well as a SharePoint hub, which you can register for to engage with. And there's a mailing list, so they're very busy. They love to keep in touch with you, and I'm sure they'll be happy to get your help and support you as needed. All right, thank you everybody so much for engaging with today. Hope you have a good rest of the day. Take care.